Hello, this is your brain on drugs, and this is Punk Rock Psychiatrist. Let's go ahead and get started with eating disorders and associate and GLP-1 use. All right. So first, eating disorders can occur at any weight, so be sure to screen. People with eating disorders want to take GLP-1s. There's a lot of folks out there with eating disorders, and they would love to get their hands on something that makes it easier for them to employ their eating disorder. And so this is something you have to be super vigilant of. And that's why we're discussing it here today. And I think this is not often discussed. I think I think it was in a 60 Minutes Australia I saw where, they're prescribing these by phone and like they don't even see the patients. I think this probably happens in the US as well. But I mean, they don't even see the patients and they just kind of prescribe it and they can't tell if the person is like extremely underweight. I watched another YouTuber, Will Tennyson. He was in Korea and he was showing like how much body image is like such an issue there. And he went to, and he's this like, really ripped, buff dude, and that has like really low body fat percentage. And he went to a Korean doctor and just like kind of walked in there and said that he wanted this medication. The doctor saw him and no questions asked, just gave it to him. All right, so like this stuff is going on, and you've got a lot of unscrupulous doctors out there that are just trying to like make a buck. And I mean, these people should be shut down. They should have their license taken away. This is absolutely disgusting behavior. And if you're listening to this podcast, you're not one of them, but you're still going to be faced with these folks coming in. And it's think of it like the opiate addicted patient, right? Who comes in, claiming pain issues, claiming, that the opiates are the only thing that work, because I mean, these people have an addiction and they need their opiates, right? And they doctor shop and go to ERs and things. Um, you're gonna have that same issue. Like GLP-1s, like these things have blown up so big. Like I'm not surprised. I've been tracking these for, like I said, what's it been, like 4 years now. Um, it's just kind of it's getting like really out of control, and this is one of the things it, that you have to look out for. All right, so let's talk about this concept. All right, so um, when if you're suspicious that this is a patient with an eating disorder, there are some questions that you could go through, or perhaps you might have your radar up and be like, I don't know if I feel good about this. Maybe I should have them evaluated by a mental health professional or something. But we don't want to create too much red tape if we don't have to. That's certainly an option. You may be, yeah, hey, I'm talking to mental health folks out there, so you guys are the ones that are going to be diagnosing these folks anyway. So get some good screening. How many diets have you been on? From what age? What has been your lowest weight and how did you reach it? Um, that's kind of letting you know, is this someone who yo-yos a lot? Are they binging, purging, stuff like that? Have you had stress fractures or menstrual changes? So like we're assessing for medical issues that could be a result of an eating disorder. Have you used laxatives, diuretics, or vomiting to manage your weight? Pretty direct question. Um, the patients could easily, the patients may be deceptive, and good chance that they will be deceptive if they know they're not supposed to be getting this and they're trying to get it. So but um, most patients are not deceptive, and they just and the other thing is you might catch them off guard. This happens all the time. Like they're not expecting necessarily for you to ask these questions, and they may not be ready with the answer. So you may be thinking, what a stupid thing for me to ask. This person's lying to me anyway. Of course they're going to tell me no. But hey, it happens to me all the time. They say yes, and you're like, oh my gosh, I can't believe they actually told me that. Because they're coming in there nervous, and they may not have rehearsed this, they may not have done this before, and they may be caught off guard. And here's the thing, just because they answer in the affirmative these questions doesn't mean we're not necessarily going to give them these medications. So we're going to talk about that in a second as well. One final question: what emotions come up around eating? So we want to assess what is this patient's history with weight, and is it suggestive of an eating disorder? And if so, we should evaluate that and see if they've got one, and see if what to do about it. Right? What is the GLP-1 really the best thing for them? Okay, so a GLP-1 can actually worsen restriction or flip a binger into restriction. So if you're already a restrictor, which is typically what we see in anorexia nervosa, GLP-1s can make this worse. It makes it easier for you to restrict. If you're a binge purger, um, it can turn a binger into a restrictor. So, now they're not binging anymore because this medication is helping them not to binge. So the medication can actually affect their eating disorder as well if they have one. And then this is a term that I heard. Let's see if I can figure out how to pronounce this. Agonorexia. Can anyone guess what that is? Agonorexia. I'm not sure quite what the intonation is, but what we're talking about here is these are GLP-1 agonists. And then, of course, rexia is, eating. So this is an eating disorder, basically. This is kind of a new term. This is not, this is not an ICD code or a, DSM thing. This is just something that people have started to notice since we've been using these GLP-1s, is that we're starting to see people that did not have an eating disorder that actually developed an eating disorder associated with the use of a GLP-1 receptor agonist, agonorexia. We'll say it that way, because it's an agonist, so we'll say agonorexia. Unofficial term where GLP-1 receptor agonist induces an eating disorder. All right, so when patients take these medications, they'll become obsessed with weight. So sometimes this happens; they become obsessed with weight loss and maintaining loss. This can reach an unhealthy proportion. Um, they receive compliments from folks, right? So people are, oh my gosh, you've lost weight, you look amazing, this is fantastic. These compliments can reinforce the need to maintain the new body size. I mean, at the same time, like, you're thinking that could be a good thing, right? Like, they lose weight, they get positive feedback, they're happy about it, they try and maintain the weight. But it's like when it goes into unhealthy territory of like, oh my gosh, I love that I gained this weight, and so does everyone else. I'm having trouble maintaining it. And so I'm going to abuse this system somehow to maintain it. And maybe I'm going to develop purging behaviors and restrictive behaviors beyond what the GLP-1 would suggest. And I'm now not taking enough nutrients, and I'm starving myself, and I'm using the GLP-1, but I didn't have anorexia before. I was just struggling with my weight, and now I'm actually thin for the first time, and I'm maintaining it, but like I'm still struggling. So that's the thing that can happen, right? So um, there may be a desire need to stop the GLP-1, can worsen this problem, right? So they may want to get off of it, they may need to get off of it for one reason or another, and then what do, right? So let's go back to our opiate patient, right? So opiate patient is prescribed opiates for a indicated reason. They now no longer meet that reason, or they're no longer being prescribed the opiates. No one will give them to me anymore. They start buying them off the street. They start getting heroin, et cetera, et cetera. You could have the same problem with the GLP-1, right? So they've had to stop it, and now it's like, yeah, well, I had to stop it or wanted to get off of it for whatever reason, but I still need to like have its effect, and so they may develop an unhealthy eating pattern um, as a result of no longer getting the benefit of the GLP-1. So that's another way this can arise, the agonorexia, right? And then, kind of contrary to what you may think, nausea could lead to binging behavior. Like, okay, I have nausea, I'm going to eat through it. Or, some people have this thought that, like, if I'm nauseous or vomiting, anyway, I might as well just eat a lot. So they may you can actually develop binging behavior. So binging being, eating more than you should at one point in time, um, and not being able to control how much you're eating, right? Nausea can actually induce that behavior. and then be maintained even after the medication is discontinued. So we've stopped it. They got nausea, they developed this binging behavior during the nausea. We stopped the med so that they don't have the nausea anymore. But now they've, you know, started this habit of binging that continues. So these are all different ways that we can have this, quote unquote agonorexia, the obsession with the weight loss, the compliments reinforcing it, the needing to stop but trying to maintain it, the nausea leading to the binging, etc. So this is a lot of stuff, right? It's not just one simple thing. We have an obsession with weight in the US for sure, right? But like all over the world, right? People are obsessed with weight. They want to be thinner, right? In our body image, we want to be thinner typically than we need to be, right? Typically than what maybe the beauty standards were in the distant past. People, a more average to slightly overweight body type was often preferred. I mean, in a lot of impoverished nations, uh, it's seen as a sign of wealth to be overweight or obese. So we've kind of flipped the script on that. It's, of course, often not, not healthy to be obese, not always, right? Some people can be obese and not have health problems. And, as a physician, I'm not really concerned about that. But of course, people have the body image issues and they want to lose the weight, and they meet the criteria for this. It's a very muddy situation. Um, and so there's a lot of eating disorder stuff floating around the whole weight obsessions that we have, and GLP-1s can make it worse, actually. So, and I think this is something that's super in the wheelhouse of mental health. I'm not a eating disorder expert by any means. um, I have, as far as I'm aware, did not have a very significant population in my patient load of eating disorder patients. I did see them from time to time. Um, they often didn't return for treatment because they don't want it. I've never worked in like an eating disorder inpatient unit or anything like that. So I don't have a ton of experience in that, but I am a psychiatrist. And so I've been exposed to this, but it's certainly not something that I'm super well versed in, as far, but probably more than the average doctor. Right. So I don't want to proclaim to be too much of an expert in this topic, but I do want to bring up this concept as, someone who is claiming to be a GLP-1 expert, that it can have some interplay there that we need to look at. So, um, what do we do about this? Um, we want to make sure we're always tracking vitals. We want to look at electrolytes, menstrual changes, their nutrition, bone health. We're getting labs. We're assessing for these things. We're following up. We're keeping an eye on what's going on. How fast are they losing weight? Are they yo-yoing? Do they have comorbid mental health symptoms going on? Even if they do lose the weight, like, are there signs going on that could suggest an eating disorder was there that we didn't detect? One's developing because of new obsessions with weight that maybe weren't as strong before, that have been reinforced by losing the weight and the medications being useful. Um, right? Let's keep an eye on this. Let's track some labs. Um, let's keep an eye on their nutrition. I mean, we talked about this in the last episode. It's super important to, like, when people are going to be restricting what they're eating, they may not be taking in enough nutrition. All right, they may not be eating enough now. They're losing weight, they're happy, but they're not taking in it. So we want to keep an eye on their nutrition. We want to get labs, as appropriate. Um, Speaking of nutrition, I've actually found, I've given you all these episodes about, nutrition and diet and lifestyle and fitness and everything. And, personal disclosure, I've had my a checkup, and my vitamin D levels are like in the toilet, like undetectable, less than 3.5. My B12 was like 190. So I've been doing this plant-based diet thing, trying to be as healthy as possible. My cholesterol levels are super low, 75, 70 something LDL, 50 something HDL. My VLDL is like 2, my triglycerides 32, like, super low numbers, A1C 5.0. So I've got really good numbers on the metabolic factors, but what kind of interests me is that I don't not consume meat. I restrict it. I don't eat as much meat as I used to, for sure, but I don't eat it that often. But I felt like I ate enough to keep my B12 levels up, and I eat dairy from time to time, but kind of surprised my B12 level was low. Folate levels were excellent, so I think that I was reading about this. It can help balance out because B12 and folate are both involved in red cell production, and so folate can sometimes compensate for the B12. So I'm in no way anemic at all. Like my hemoglobin was like 13.8. So even here, me, Mr. Nutrition, like I'm taking a B12 supplement. I'm gonna be following up. I actually have decided that I'm gonna start eating meat more often, um, which is also partly because I've been trying to like work out in the gym and get bigger, and those satisfied with my results, um, I want more. And I feel like my diet may have been an impediment. And the fact that my B12 levels are low was just like another push to like, hey, let's try meat and see what happens. So I'm going meat and eggs, and see what happens. And then the vitamin D, we had an episode on vitamin D. I've had low vitamin D in the past. It's never been this low. So I think that if you're restricting meat, B12 is definitely something you need to be looking at, and vitamin D is something that we all need to be looking at. It's just something we all need to be looking at. Like no one gets enough sun for the most part, um, and the only food that's really rich in vitamin D is fish. And if you don't eat fish like me, um, seafood, then you're not going to get enough. It's just not. And if you're not eating processed foods, then you're not eating things that are fortified with vitamin D either, which I avoid processed foods. And then mushrooms that are put into the sunlight will make vitamin D, but you'd have to eat them like every day. You'd have to eat like a serving of sun drenched mushrooms every day to get your vitamin D that way. And I just don't think anyone eats that many mushrooms, and it would just be difficult to maintain that. So a vitamin D supplement is not, it's something that I think that probably most people need. That would be, if I'm going to push one supplement, um, vitamin D is probably one. So, even when you're trying to follow like the healthiest diet that you could possibly imagine, you can run into problems. And on the flip side, hey, say I go the meat route, and then my cholesterol and stuff starts tanking as well. So it's a balance, right? And there's no problem with just taking a vitamin D and a B12 supplement and keeping all those other metabolic factors even. I'm just, playing around with things, seeing where they go. I'll report back in a few months and let you guys know how it went. But just a little personal story there to kind of think that even people that are being super careful about their nutrition, and by the way, I am avoiding saturated fats. I'm eating 96% lean beef. Just going to see where that goes. So let's take an eye on nutrition when we're taking GLP-1s. All right. So do not use GLP-1 with the following eating disorders: anorexia nervosa and ARFID. Now, all of you may not know what ARFID is. It's avoidant restrictive food intake disorder. So it's associated with autism, not always. It's it's a disorder. ARFID's a disorder where people avoid foods because of sensitivities and not because of concerns about weight and other things like that. It's more like uh, they have psychological issues for not eating certain foods. They're sensitive to it. It makes them vomit, and there's lots of foods that they can't eat. So if you're already restricting because of that, we don't want to give these folks another medication that would reinforce that restriction, because then they're at risk of even more deficiencies. And then anorexia, of course, a lot. I think there's some overlap that people don't talk about between anorexia and bulimia. There is. We think of anorexia as underweight, and we think of a bulimia as normal to overweight. All right. And that's generally the way it is. And we think of bulimia as binge purging behavior, which it is. And we think of anorexia as restrictive behavior, but there is a binge uh, purge type of anorexia as well. Generally, with anorexia, you're going to be below 18.5 BMI, and with bulimia, you will be above that. However, there's atypical anorexia, so there can be some confusing overlap. But if you're a restrictor and you're underweight, that's anorexia. If you're a binge purger and you're normal or overweight, that's bulimia. If you're around normal weight and you're a binge purger, it could be anorexia. So it can be muddy in there. And we're saying anorexia is a more dangerous disorder to have. um, some folks that used to be really big lose a lot of weight, and they don't become underweight, but they're anorexic because they're highly restrictive to maintain their normal weight, and we call that like an atypical anorexia. All right, so that gets really in the weeds, and like I said, not a super expert on this stuff. um, but yeah, don't use them with anorexia or ARFID. Restrictive behaviors are bad, and if especially if somebody's already underweight, why are we giving this to them? But a lot of time, folks aren't checking. Like I said, on Will Tennyson, he's not overweight. I mean, his BMI is maybe because he's a muscular dude, but they gave it to him anyway, right? And then doing people doing it through the phone, etc. Don't do that. I that's a terrible idea. And I've heard like, oh well, they have to send in a picture. How do I know that's you? And how do I know that's you right now and not you 5 years ago? It's just bad news. If someone can't come in for an appointment, then they don't get a GLP-1. This is not a mandatory thing. You don't just get one because you want it, right? I was just watching a podcast. Dr. Mike was interviewing Mike Israetel, and like Mike Israetel he basically wants anyone to be able to take anything, regardless of, they take on the risks. Doctors are, just a doctor's job is to warn you of the risks, and then if you want to take it on, you can take whatever you want. I think this is an absolutely insane idea, and I've lost a lot of respect for him over the last several months. I think he's gone off the whatever. He's just not someone I would listen to anymore. Dr. Mike is probably one of the best sources of medical information in the social media realm. So I do highly recommend him. I think he is fantastic. He does what I do in like a much bigger scene in like every area of medicine, and he does it in a fabulous way. So I think he is like top notch. So um, yeah, this idea that, oh well, I've warned you, and if you want to kill yourself with this no, I'm not doing that. Don't do that. I don't do not like this at all. People should not be like able to just do what the heck they want. And we'll get to back to that in a second with another issue. So appetite suppression and delayed gastric emptying can worsen these disorders, right? The anorexia and the ARFID. So and the patients are particularly susceptible to relapse if meds are discontinued. And then let's talk about the other two eating disorders, bulimia nervosa. So fluoxetine is first line for bulimia nervosa. GLP-1s are not FDA approved for bulimia nervosa, but they are approved for obesity. They can be used with caution in bulimia patients. So it's not an absolute, you cannot use this. There have been some small studies on this. If the patients are able to control their weight with the GLP-1s, they may stop their binge purging behavior. It may actually work out for some folks. It may make some folks worse. So it's something to kind of be careful about. With the anorexic patients, with the restricted patients, we don't want to use this at all. We don't want to help people restrict that are already restricting. But if someone's a binge purger, you could consider it. But you're going to have to watch really carefully. We're going to have to follow their labs. We're going to have to follow. You're going to have to. You're going to have to put a lot of work into that patient. If you want to go down the road of giving a GLP-1 to a patient with bulimia, you're going to have to spend a lot of time with them. And if you're already, say you're doing therapy and you're seeing this patient on a frequent basis, they failed every other treatment, You're a prescriber. Hey, maybe we try a GLP-1 with that patient. You're doing therapy on them. You're seeing them regularly. That might be a good candidate for a bulimic patient to take this medication. But if it's just like set it and forget it, and then you don't know what they're going to do, that may not be such a good idea. And then as far as binge eating disorder, so difference between bulimia and binge eating disorder, we purge with so purge is not the best term, compensatory behavior. So with bulimia, you binge, so you intake a lot of calories more so than you need to at a given time, and then you compensate for it. That could be self-induced vomiting. That could be taking substances that help you vomit, whether it's ipecac or something like that. It could be taking laxatives so that it goes out the other direction. It could be exercising a ton to try and burn it off, right? Some sort of compensatory behavior. In our binge eating patients, they don't compensate, they just binge, right? First line treatment for that is lisdexamfetamine or Vyvanse. We've talked about this before. There are a couple other medications like zonisamide, and oh man, I think it's it may have been topiramate. I think it's not. There's a couple other ones that, like in my formulary, you have to try those before you go to lisdexamfetamine. But lisdexamfetamine is actually the only FDA approved treatment for binge eating disorder. But you could also definitely consider GLP-1s in these patients. These would be the lowest risk eating disorder patients. In fact, sometimes um, the this is a decent treatment for them. So, but that doesn't mean that we don't have any risk. We already talked about all the risks. This is associated with all eating disorders. So, hopefully, we had a nice talk there on eating disorders, and now you're aware. Hey, yeah, I haven't heard that discussion, and those are a lot of good points to think about. So, um, moving on, let's talk about. We're going to continue with some of the downsides of GLP-1s. Let's talk about drug interactions. So when I look in the lexicon or whatever the heck we call it, and not lexicon, the lexicomp, right? And we see what are the drug interactions. They list androgens, beta blockers, direct acting antiviral agents, insulin and other diabetic agents, MAOIs and SSRIs, fluoroquinolones, salicylates, thiazide and thiazide-like diuretics, diabetic aid, and these are all listed because they may enhance hypoglycemia. That's why. So remember, if a patient doesn't have diabetes, then they're not, if we're just treating obesity, they're not at risk for the hypoglycemia with these medications. And a lot of those medications I listed, like SSRIs, are pretty low risk for hypoglycemia. So, I mean, it's something to know, certainly. If you've got a patient with diabetes, there's some hypoglycemia. I mean, it could be the combination of GLP-1 with these other medications. So, not something super common that's going to come up. And just to kind of let you know, like the risk. So we have things in risk category C, D, and X. X meaning like, yeah, don't ever do this. C being like, hey, keep an eye on this, and D being like, you might want to consider not doing this seriously, right? But maybe if you have to, go ahead, right? So those are kind of our categories. So the diabetic agents in that list are all class D, but the other ones are C. So like our SSRIs and beta blockers and stuff like that, those are class C, so lowest risk. But if you're managing diabetes, of course you're keeping an eye on hypoglycemia with GLP-1 if they're taking other agents. So, and of course these might, compound on top of each other. So that's something we're probably paying attention to and that we don't need to be like super alerted to, right? And some other drug interactions you may not be aware of. So it can increase the serum levothyroxine level. So if you have hypothyroid, low thyroid hormone in your body, and you're taking levothyroxine, the thyroid supplement medication, um, taking the GLP-1s could increase that. It probably has to do with just how the gastric emptying is affected and things like that. So if someone's on levothyroxine, we're already checking thyroid levels, but we may not be checking them super regularly because they've been on a stable dose. So if we're going to be using the GLP-1, I'd probably just check the thyroid, to the TSH, make sure that we don't need to change that dose of levothyroxine, because if it's going to increase its levels, we may need to lower that dose, right? And then again, if we stop a GLP-1, we may need to increase it. So if we're going to be using the GLP-1s with the thyroid, check their thyroid. I know that's not something that's out there anywhere. We're probably checking all obesity patients for thyroid in the beginning, but that's just a kind of an extra level of caution. Another thing, tirzepatide. When we talk about tirzepatide, we're going to bring this up again, but tirzepatide may make oral birth control less effective. And I've just been wondering, like, this is a warning that's on there. It's only for tirzepatide. I don't know why it doesn't exist for a single other GLP-1. And so, I just looked it up. I was like, why the heck is this warning even there? And it's has to do with the gastric emptying. And it's like, oh well, the slowed gastric emptying may mean that the hormones are not getting into your system in the way that they need to give adequate birth control. And so we recommend you use alternative agents. And I'm like, that's not very satisfying. A lot of people take birth control, and a lot of people are taking, this is Zepbound, right? A lot of people are taking tirzepatide now. And I don't know how many people are paying attention to this. And I don't know how many people are getting pregnant on accident because of it. I mean, I'd like some numbers. And I'd also like to know why this warning doesn't we don't have this warning on the other meds, and because they do the same thing. They have the same effect with the slowed gastric emptying. So but certainly if you are trying to avoid becoming pregnant and you're taking a GLP-1, I don't know, is your birth control going to be adequate, and how will you even know? How will you even know until it fails? So and this is the best option. So this is the oral birth control. So my advice would probably be use one that's not oral. That would be my advice, because the advice is use other means until you can like ensure it's working or something. And I'm like, how do we know that? So IUD, implant, injection. I would not play with fire on this. Let's not. I just I would be pretty darn careful about using oral birth control with any. And even though the warning is only on tirzepatide, like when you're trying to avoid pregnancy, you want that to be 100% effective. You don't want to introduce something into the system that could lower that. So I would be super careful about that, and I'd make sure people know. I don't think patients are warned about this either. Let's talk about lithium as an interaction. So there are case reports showing increased lithium levels when they take GLP-1s. So hey, this is right in our wheelhouse here in mental health. Um, yeah, so you may not be the one giving them the GLP-1, or you might be, but you may certainly be the one managing their lithium. We're going to want to check those lithium levels. So people get dehydrated when they take GLP-1s, because they don't want to drink as much fluid. We've talked about that. Could it affect absorption of lithium because of the gastric emptying issues, like slower, so we definitely don't want our lithium levels to go up or down, and up, can often be worse than down. I mean, if they go too low, their symptoms aren't controlled. If it goes too high, they could die. So, I mean, I don't know how likely it is that their lithium levels go from normal to like death level from taking a GLP-1, but if lithium levels are higher than we want them to be, that can cause a lot of other issues, even if it doesn't put them in a coma. So we want to make sure that we have those lithium levels right where they always have been, and not too high, because they can cause uncomfortable side effects, and they can also cause kidney damage and things like that over the long term. So definitely want to monitor lithium if they're on it while taking a GLP-1. Once again, this is just case reports, but probably more to come on that. All right. And then here's one that I just kind of came up with, not mentioned anywhere, never heard about it. I just kind of theoretically am throwing this out there. With the decreased gastric emptying, I'm thinking that could interfere with the extended release formulations and meds that need to be spaced out from food or other meds, right? Because if you're saying like thyroid or whatever, there's a lot of medications that you have to take spaced out from food. Well, if I'm delaying my gastric emptying, is that not impacting how that spacing out is occurring? If I'm taking extended release medications, might that not, if I'm delaying the gastric emptying, might that mean that like we're not getting as much drug as we were before as soon as we were, and then it might be lasting longer than we had planned for it to be, right? Because it's like going from the stomach into the intestines where it's absorbed more slowly. And so, like, what might the consequences of that be? I think if you're taking one of these meds that's like a 24-hour med, right? Like, this is a blood pressure med, Toprol XR. I mean, I'm just XL, right? So, I mean, just to throw something out there, something like that. Well, I mean, we want that acting all the time anyway, so this is not really going to be an issue. It's just it'll slow it, but we'll still get to steady state and we should be fine. Shouldn't really affect it. The steady state should balance out. It's not going to mean you're not going to get less drug absorbed. I mean, there is the potential that if you have a slower emptying, you may absorb more of it because it doesn't move as quickly through your system. So, potential that you may need to lower the dose because maybe it's being absorbed more effectively because of the slower. I just something to consider. You know, if somebody's blood pressure goes down, it could be because they've lost weight and this thing is working. It also could be because the med they're taking is more effective because of the gastric emptying issue. Um, Another reason why we're monitoring vital signs, and we want to certainly adjust those blood pressure medications if we stop or start these meds if needed, right? Also, think about stimulants, right? ADHD. We just finished our ADHD series, right? Not too long ago, and we don't want stimulants lasting too long. It affects sleep. If I feel like gastric emptying, if we're slowing gastric emptying, one, this may not be kicking in, and we might be like, hey, this thing isn't working, and then wait, I can't sleep because oh wait, it took like several hours before it worked, and it usually works faster, and now it's like working when I don't want it to work. So you may need to switch to like a shorter acting med, perhaps. And let's think about sedatives. They may, we're taking these to help us sleep. Take it some Ambien or something. It may last too long, and then we're tired in the morning, right? So I'm thinking about mixed amphetamine salts, Adderall XR. I'm thinking about 5-ants. I'm thinking about Concerta. I'm thinking about Zolpidem XR. I mean, interestingly here, I put others question mark levothyroxine, and I think that was before I even got this may increase serum levothyroxine levels. So that was kind of a theory I had, and then someone actually reported on that. And so, you may need to lower the dose of the XR. You may need to switch to IR twice a day. You may need to take the XR even earlier than you're taking it if possible. So, if you're noticing something else that's changed with the GLP-1, perhaps it's the delayed gastric emptying impacting how the medication they're taking is absorbed, right? Especially if like timing is important. And I know ones that I think timing is the most important would be stimulants and sedatives, because we want stimulants to work during the day, sedatives to work at night. Most other things we kind of, antidepressants or something like that, we want those working all the time. So it's not really an issue. But of course, we have antidepressants that are more stimulating, and so they're going to be higher right after you take them and lower at night. And so something like Wellbutrin, which is kind of a stimulant antidepressant, but it is a 24-hour acting medication, especially the XL formulation. And so, perhaps they start not sleeping as well when they take the GLP-1 on the Wellbutrin, and maybe we need to switch them to the SR. I don't know, or different. We need to think about that, right? So I think that those are some interesting things to think about. And let's move on from drug interactions and let's talk about cost, shortages, compounding, that whole thing. All right. So shortages are not as much of an issue recently, because I think it was crazy. Like, these drugs took off like gangbusters, and the drug companies couldn't make enough of it. And it was just flying off the shelves. I'm like, dude, you guys are leaving money on the table, and somebody's making it, somebody's compounding this and making it, and they're making money. But the drug manufacturer doesn't seem to be able to get their butt in gear and make it. So there were shortages, and shortages do happen with these meds even now. So let's just talk about the whole issue of shortages and compounding, because like there are other issues with compounding. So it's all kind of interrelated, and the cost too. This all kind of plays together. So let's talk about shortages first. A lot of people are paying out of pocket for these meds. So like I said, they're getting them for vanity. They're not necessarily meeting the criteria for them. They're not actually obese. Doctors are just giving it to them. They just like pill mills. Don't do this, right? But it's happening. So like way more people are taking these that necessarily need it. And what was happening is like even people that were taking it for diabetes, like what was happening was, oh, we're out of Wegovy, right? This is years ago. This is like before Zepbound was approved. Oh, we're out of Wegovy. Let's give people Ozempic. And Ozempic is supposed to be for people with diabetes. It's not even like the same doses. And now diabetes patients can't get their freaking diabetes meds because you've got these patients that don't need these weight loss medications. The wealthy, they're paying out of pocket. They're getting these. They're flying off the shelves, and these people that have like a real significant medical necessity aren't able to get them. That was happening. Um, One thing that I've recommended is, Saxenda. We haven't talked about these meds yet, but Saxenda is like the least used of our GLP-1s, the least effective for weight loss. But because of that, because it's not used so much, it's often more available because people aren't using it. So if you can't get Wegovy or Zepbound, maybe you like bridge people onto Saxenda. We'll talk about how that could possibly work. One cool thing about Saxenda is that its pins are multi-use, which has its pluses and minuses, and we'll talk about all this when we talk about Saxenda in detail. But because they're multi-use and you can basically click out how much dose you want to give, you have more flexibility with that, and so you can try and come up with a equivalent dose of Saxenda to bridge you. And we'll talk about a little more how to do that later. But I just wanted to bring it up as like maybe one of the solutions to this. If there's shortages, we can like pop them onto Saxenda to at least give them something. Um, Wegovy is often available at higher doses. So like the starting doses aren't available, right? The 0.25, the zero point 0.5 were not available. And now that we've got Zepbound, rather than bridging with Saxenda, it may be Wegovy that we have, but we can't find any Zepbound. So we could bridge with Wegovy. That's another option. So if the lower doses of Wegovy are not available, you can initiate, like say you want to start people on Wegovy and there is no Wegovy. Well, you could start them on Saxenda and titrate. You can actually titrate up faster with Saxenda, so you could get them up to the 3 milligrams and then switch to 2.4 of Wegovy. So basically, let's get them up to the dose of Saxenda, and then the 2.4 is not in a shortage. It's only the starting doses that are in a shortage, and then we pull up we use the Saxenda that's available just to get them on the med, and then we go over to Wegovy later. So that's a strategy you could employ with the shortage. You could skip the 0.25 milligram dose of Wegovy can pretty easily be skipped over. So if that's the only dose that's not available, you could go straight to the 0.5. You could even consider skipping the 0.5 if you want to try that. I would not skip the next dose up by any means, but you could definitely skip the 0.25. I mean, they may not tolerate that, but it could be tried. And the other thing is, Wegovy can actually be dosed by clicks. This is not like in the manual or anything. A full dose is 74 clicks. You could just like not click it that much. And so basically, the Wegovy are single use pens, whereas Saxenda are multi use. So you basically, you're not going to use the same needle twice. You're going to use the same vial. It's preloaded with a certain amount of Saxenda, and then you put the needle on there, you inject it, and then there's still some left in there. You dispose of the needle next time you put a new needle on there, and then you inject more of what's left in that vial. Whereas Wegovy it just comes in one pin, one dose. You inject it. That's everything you get. You toss it. However, kind of like on the sly, you could give them a higher dose of Wegovy that's available and just say, hey, the full dose is 74 clicks. Let's do half as many clicks of that so we can get the dose that we wanted. And then you're going to have to toss it because I don't think that you can't change the needle out. You just basically have to waste the rest of the Wegovy. But it's an option. Other countries outside the US have made a dial-in dosing of Wegovy easier, but not in the States. So if you're in another country, that may not be an issue that you face. But these are all little tips that you can use to kind of get around these shortages. And then Zepbound, actually, they made vials available. I don't know if they're still available. So there was the pin version and there was a vial version. So the vial was actually, you got an actual vial, like a test tube, and you like stuck a syringe into it and draw up the amount of the fluid that you want, inject it, and then you still have like amount left in that vial. And you'd only dose this once a week. So then you save the vial in the refrigerator and you take some of it later. So if you don't have if you can't use the pin version of Zepbound, you could use the vial version. So that was a backup. And the company made that. I don't know if they still do make it. It's kind of off and on with shortages that they'll make the vial available. Some insurance coverages won't cover the vial. You can't order it. But that is something you want to make sure you're getting the brand's product and not some off-brand thing. So let's talk about cost now. So many insurers will not cover these medications. Medicare and Medicaid had previously like basically said, we're not paying for this at all. All right. So, but now the situation is a little bit changed. It's a may not pay for weight loss or may pay. Kind of depends on some stuff. So just recently, this is actually this month, just serendipitously, this just happened as I'm making this episode. Medicare has a new program that just came out in July of 2026 that covers those with Part D Medicare and medical comorbidity in addition to obesity. So if you've got obesity and you've got one of the comorbid symptoms, now you don't need the comorbid symptoms with obesity to get some insurance companies to pay for it, but for Medicare, you do. Before, they wouldn't do it at all. And now, if you have obesity and a comorbidity, and pretty much, most people do, high blood pressure, cholesterol, we'll go through those, sleep apnea, all those type of more comorbidities that go along with obesity. If you have one of those and obesity, there's a $50 copay, so significant reduction in cost, and Medicare will cover it. That's new. All right. Medicaid is managed by the states. So some states, Medicaids will pay for it and some won't. Okay, so there's that to be considered as well. You may be in a state where Medicaid pays for it. You may be in a state where it doesn't pay for it. And that could change. They may allow it or not allow it in the future. If it's bankrupting their state, they may cut it off. If, these become cheaper and more ubiquitous in society, they may get covered, right? We don't know what's going to happen. So it just changes with the times. All right. So, and also with Medicare and Medicaid, it's not just obesity treatments that are not covered. So fertility treatments, so like trying to get pregnant, stuff for that, drugs for cosmetic purposes, hair growth, symptomatic relief of cough and cold, vitamins and minerals, except prenatals. All those things are typically not covered by Medicare and Medicaid. So it's not like these medications are being singled out. And it's not just the GLP-1s, it's all weight loss medications. All right. So it's all of them. And working in the military system, we'll talk about this later because I'm going to give you once we talk about everything, I'm going to walk you through the whole, like how these get covered in my system. So you can kind of see an example of how to navigate the system. And if you're in my system, you're in luck. You'll get to see how it works. But you may be in one that works similarly, and I'll show you how to navigate it and get through it, and how it works. It's something you have to learn, and they change it every year. They've cut off. The military has now cut off beneficiaries that have TRICARE covers that are not active duty or dependent. So if you're like a retiree or you're like overseas and you're a civilian or something, like these folks they're not getting it anymore. So that's a change. So we'll talk about all that too. And then also Medicare and Medicaid used to not cover smoking cessation. They used to not cover barbiturates, and they used to not cover benzodiazepines. So these things do change. They do cover those now. All right. How much do these things cost? It's a lot. $800 to $1,600 a month in the US. Like, it's pretty insane. I mean, that's full price. Okay. Other countries, I'm talking about countries in Western Europe. I'm in Japan, $100 to $400 a month. So we're talking about four times, if not more, less in most other countries, in almost all other countries other than the United States, obviously this is the case with all medications in the United States, we're getting gouged by the companies that have a grip on our government, right? So if you're in another country, you may not be that concerned about costs in these meds, but in the US, we darn well have to be. Um, there are some ways to help with this. Oftentimes, you can require a reduced price product that's about half the price directly from the manufacturer. Sometimes they have the coupons available for that. Compounding pharmacies, we're gonna go in deep on compounding pharmacies here. So compounding pharmacies provide easier access at much lower cost, but there are a lot of caveats for this. All right, so two to $500 a month instead of $800 to $1,600 a month. Um, Compounding pharmacies are not covered by insurance typically, so you're going to have to pay out of pocket, but maybe you had to anyway. You may not have been able to get it covered, or your doctor may not have been able to jump through all the hoops to get it covered anyway, but they'll still write you the prescription if you're willing to pay out of pocket. Compounding, they dose it by syringe. They don't have the pins. The pins are patented products. They use just the syringes. So these are more challenging for patients to use. Sometimes patients will confuse concentrations, the units, the volume, and they inject too much or too little, which can be dangerous or useless. The vial concentrations differ from between different compounding pharmacies. So if they switch from one to another, they'd be like, "Oh, I always take up 3 milliliters." Well, it's not 3 milliliters this time because the concentration at this other pharmacy is different. So like, if patients are using compounding pharmacies, you have to like help them not take the wrong dose, which is a lot to research. Like most doctors are not going to have this kind of time. It's important. Also, it's important to ensure that patients understands how to dose with each pharmacy. Okay, which is pretty much what I just said. And beware of sublinguals; they don't work. There's some compounding pharmacies out there that are offering sublinguals. Those are not effective. We know we have some more oral options now. Um, since I've been doing this series, oral Wegovy has come out, um, or Flogopron has come out. We're going to talk about all that later. Um, let's finish up the episode with a deep dive on compounding. All right. When I first learned about what is compounding anyway? Right. So these are pharmacies that exist out there that basically mix their own drugs. Right. Compounding essentially is they take what typically what happens is a manufacturer, be it a generic manufacturer or the brand name manufacturer, uh, creates the product in their manufacturing facility, and they ship it in to these pharmacies, and they print the labels, put it in the bottles, inform the patients, etc. A compounding pharmacy is doing their own mixing. They're taking the raw product and putting 5 milligrams in their own pill, right? So they basically have their own little receptacles, their own little capsules that they have in their compounding pharmacy. They're measuring out they're ordering the product, and then they're measuring out the amount that that has been ordered, and they're putting it in there themselves rather than the manufacturer doing it. And this often saves money, but it also has some risks and also some illegal activity, and that's what we're going to talk about. All right, there is legitimate compounding and there is illegitimate compounding, and we are going to talk about both right now so that we can all be informed of it. All right, so compounding is allowed if the FDA declares a shortage. If the FDA does not declare a shortage, you are not allowed to compound. But with the GLP-1s, it was happening anyway, right? Why might this be? Why might the FDA declare a shortage? So it's designed to help patients that are already on medications, right? I'm taking this for my diabetes. Now it's not available. What am I going to do? FDA declares a shortage, compounding happens, more products available, these patients remain on their meds. It's not designed to start new patients, but this is another problem. I don't think it's illegal to start new patients, and this is what people were doing. So they were then starting new patients on GLP-1s through the compounding while we had the shortage declared. And then what happens when the shortage ends? Well, our patients that were previously on them, they can get them because they were getting them before the shortage. They were getting them from the legit, or I wouldn't say the compounder's not legit. They're getting it from the standard pharmacy. So they can go back and continue to do that. But for folks that were started through the compounding pharmacy and they were getting that cheaper price, they're not approved to get it through the standard means and may not be able to be. So these new patients may not be able to get the medications once the shortage ends. So now that the price has gone up from $200 to $500 a month to $800 to $1,600 a month, and their insurance isn't covering it, they can no longer afford it. And we've just wasted starting these patients on meds. So like, don't start new patients on meds from the compounder when the FDA declares a shortage. That's to help bridge people. It's not to start new. Unless you think you can get that patient approved, and you should be working that through. Because the thing is, you can get them approved to take a medication even if it's not available, and then you can prescribe it through the compounder. So you should be doing both. Don't just say, oh, you can get it at this compounder, it's available and it's cheaper, and then not get them approved for the med for their insurance, and then the shortage ends and then they can't get the med. Like, that's pretty irresponsible. Don't do that. Okay. But you may not know because I mean, I just learned about this whole compounding thing in the last few years. They don't teach you about this in medical school. Um, I didn't even know that this was a thing. This should definitely be in the medical curriculum. All right. So there's a lot on this. Okay. So compounding is allowed if, in quotes, not a commercially available copy. All right. So if there's a shortage declared, but also if it's not a commercially available copy. So now we're getting to shady territory, which is still legal. That means drug dose and route. So if if an oral product is available, but you want to give it um, rectally, you can compound it and do that, right? It's not available, so I'm allowed to compound it. And if the dose, hey, the dose is 2.4 milligrams of Wegovy. What if I want to give them 2.2? Hey, that's not available. I can compound that. Oh, and then the drug. Oh, I want to mix these two drugs together. Oh, they don't exist in a commercially available product. I can compound that. This is a lot of help. This is another way that people get around it. So if you're adding something, and normally what they're adding is some BS thing, right? They're just trying to do this shady thing and get this cheaper med through the compounding process. So what they'll do is they'll just like mix it with a vitamin, mix it with some inert substance that technically qualifies as adding something, but it really has no scientific evidence to mix with this other product and do anything substantial. It's just a way to get around this. It's like a loophole, right? So they may add something, most commonly a vitamin, or they might remove something like an inactive ingredient. Say that the standard product has an inactive ingredient. It's like, oh, my patient's allergic to that inactive ingredient. I need them to take one without it. And are they? Well, you don't have to prove it. You just have to say it. So then they'll say, oh, they're allergic to this inactive ingredient that's in there. I need you to compound something that has the drug in it without the inactive ingredient. And then they can get away with selling this. All right. And then as long as you change the dose by more than 10% from what's available, say there's a 5 available and a 10 available, and you want to give them a 7.5, well, is that more than 10% difference from 5 or 10? Yep, because 10% of 10 is 1 and 10% of 5 is 0.5, and that's 2.5 away from both of them. Hey, 7.5 is not available. That's the dose I need for my patient. So then you can get that compounded. And so that's another way that they'll snake around the system. And then another way to be able to compound legally is you can get an exception to the above, which is the drugs on demonstrably difficult to compound list. And so this is another way they go around it. And then the manufacturers are actually they're petitioning for this. Oh, sorry, I got that backwards. So the exception to the above, right? So the way that you would not be able to compound if it is not a commercially available copy, drug dose, route, or there's a shortage, you can get an exception to that. So a drug manufacturer like Eli Lilly or somebody who makes these GLP-1s, they can ask to have their drugs on a demonstrably difficult to compound list. They can basically, the DDC list, they can say, hey, I don't think our drug should be able to be compounded. I don't think that it's too difficult. Put it on this list. And if I get it on that list, then you're not allowed to compound it. And then if you compound it, it's illegal. So the drug manufacturers are actually petitioning for this. I also think this is shady because I think that if you can't make enough of your drug and you have a shortage, and you know it can be compounded, that it should be available that way, and you should get your act together. And they're just trying to, like, get around. They're trying to get around. This is them trying to get around the system, but also like they're also trying to cut off some of the shady stuff as well. So like, of course, it's two conflicting people that are both trying to be as legally shady as possible. And I think a lot of people, whenever they're like, yeah, you're trying to make a lot of money, and so I'm gonna go this way. It's like, the direction you're going is just someone who's trying to make a lot of money too, right? Like, you think the medical establishment is corrupt and you don't want to follow it, so you go over to some, vitamin quack, hawker that's hawking some peptides or something that's completely unproven, that you don't even know if what's in there is what they say is in there, and you think that's not corrupt. Like, you're going from one corrupt system that's actually, like, at least um it's at least regulated, over to some completely unregulated system that has no evidence, that has no proof. We don't even know if what's in there is in there. Vitamins, we don't even have to, like, prove that the amount that they put in there is in there. We have way less control, way less regulation. Oh yeah, that's a great idea. That's an excellent idea. And so it always, I mean, I can understand the mistrust in our standard system, and it needs to be fixed. But like, when you're like, hey, I don't like this system, I'm going to go to this crazier system. I mean, it's not better to go to something that's worse. I mean, okay, so there's no perfect solution out there, and everyone thinks that they know everything. With this exception, the drugs are demonstratively difficult to compound. Also, so currently the compounder's product is made in a different way, and the manufacturer is basically arguing that the fact that they're making it differently is making it to where the drug is not as effective. So I'm not sure if this has been resolved, but like, this is something that goes on in the whole compounding world as well. So these manufacturers may be able to say, I'm going to make my product unable to be compounded, and the competitor, they don't make it right. So what's the problem with compounding? So like, those are kind of the legal ways that this works, because it is legal. Like, when I first heard about it, and I was like, wow, seems shady, that like we're getting these compounded products coming in from India and stuff. And a lot of that is shady, but some of it's actually legal. It's not all illegal. Like, compounding is legal, and you can compound patented drugs that are currently under patent, if you meet those not commercially available copy and shortage requirements. However, quality control of these products has been a concern, and I got a lot of things that point to that. There are reports of not yet approved GLP-1s being compounded. People are taking retatrutide. Um, I've been told that this is pronounced retatrutide, but I think that sounds stupid. So I'm going to call it retatrutide, because I like to call it semaglutide, tirzepatide, um, liraglutide. You can call it liraglutide, semaglutide. No one calls it tirzepatide. Everyone calls that one tirzepatide. But apparently the drug manufacturer is calling it retatrutide. But and then, we got two competing companies here. We've got Novo Nordisk and we've got Eli Lilly, and like, one of them saying no, it's this way, and another one saying, oh, you can say it whichever way you want. So you will hear both. Just want to let you aware of that. So retatrutide has not been released yet. I like to call it retatrutide because I like to keep them all with the same kind of pronunciation, um, method of emphasis, um, on syllables. So we will await its approval. We don't know what its brand name is going to be, but it's already out there. You can get retatrutide. You can already get it, and like, it's not even approved by the FDA. But I mean, people are taking steroids and stuff. This is going back to Mike Israetel, who, formerly known as Dr. Mike Israetel with his phony PhD. It's actually, I mean, he was awarded the PhD, but like, it's a really crappy dissertation, and it's a really crappy dissertation. If you know anything about the world of fitness influencers and you've heard of him, check out the video that are like he's a bit of a con artist in my but at the same time he has a lot of interesting things to say, and he's interesting to listen to. And I used to follow him until I got sick of him. But he's on steroids, which is like for me the biggest reason not to trust him. I'm like, why am I going to trust your advice when you still take steroids? Like, why are you the one I'm going to listen to? I want to listen to someone who doesn't take steroids. I want to be a natural lifter. I don't want to be I don't want to take dangerous substances to enhance myself. But that's like his thing. Like he proudly takes steroids, and he's like, oh yeah, I think people should be able to do this kind of stuff. And we got the peptides now floating around, which are shady in my opinion, and we've got retatrutide floating around. Now, retatrutide almost certainly, in my opinion, is going to be FDA. Well, my opinion, my guess, I think it's going to be approved probably this year. Its final results have come out. Everything looks good. We're going to talk about it. I mean, it may be approved before I even get to it, but I'll probably get to it in the next couple episodes. But it's going to be approved almost certainly, and it'll be available. But people are already taking it from a compounding pharmacy. I mean, this is illegal. This is an illegal substance. And this is one shady thing about compounding, is that people basically are taking all kinds of crazy stuff that they're not supposed to be taking, but they're taking them anyway. So that's something shady that compounders do. Next, so there are reports of unauthorized salt forms of GLP-1s being compounded. This was a while ago, 2022, 2023. I don't know if this is still out there, but this was an unauthorized salt form. It was not supposed to be used, and it was available. Also, reports of being given at spas without prescriptions. So there are spas that are basically just, I mean, you guys know what these spas are. These like this people go there and they get massages and saunas and 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 Botox is often given at these spas, and creams, and uh, the whole salmon sperm stuff is there, and like, but I mean, a lot of this is legitimate stuff being given in a legitimate way. However, you can't you can't give prescription products without a prescription. And a lot of these spas don't have a prescriber there prescribing these products, but they just have these that they got at compounding pharmacies. And, this is mostly wealthy, entitled people, skipping the system with their power and money, going to these fancy spas, getting their little spa treatments and stuff. Not that I think that's a bad thing. I think it's good to relax and get proven treatments and things, but like, I think there should be a doctor administering it, or prescribe. I mean, or at least prescribing it, and then like someone who's certified to administer it, be it a nurse or whomever, an esthetician or esthetician, is that how you say it? I think they can give a lot of these products. I mean, I don't want Botox administered unless it's an expert that knows what they're doing. But yeah, there are spas that are giving this out. They're not supposed to. I don't know. There's so much illegal activity that happens. It just floats right under the radar. These compounding pharmacies, so sometimes they'll put impurities, counterfeits even, and contaminations in products. They're I mean, this is like what people do with street drugs. They like cut your cocaine with like powdered sugar or something. Like, it's they're trying to stretch a dollar. I would not take chances on this. So these products must come from FDA approved pharmacies. So these compounding pharmacies, to legally operate, they have to be approved by the FDA. All right. So, and the American Diabetes Association recommends against the use of these products due to these concerns. So the ADA says don't even use these compounded products. All right. So, however, there are legit compounding pharmacies. Let's talk about how that works. So how to safely use this. So it's a lot for you as a doctor to actually take on, and probably more than you're going to want to. And you're probably going to be like, you know what, I don't want to mess with these compounding pharmacies, um, unless you're like, I mean, the people that mess with them are like private folks that are like, oh, I'm going to make my own product. Like, I wrote a paper on atenolol, and I had this guy reach out to me, and it was one of the papers I referenced in my paper. He was basically mixing atenolol with like, what was it? Um, he was in atenolol is something that's been off patent for like ever. This is like a drug that came out in the 70s, and that he's basically giving it for the same reason that I was for hypervigilance, particularly PTSD, anxiety attacks, stuff like that. And he was mixing it with it's one of the things you use for like seasickness, some anticholinergic medication, and he was basically saying that the combo would help with the anxiety attacks. And the other thing he had in there was something like that was completely unneeded. But basically, he's compounding the two products together to make a new product so that he can sell it as a product and make some money, right? So that's who's doing this in many cases. Of course, there are legit ones where it's like, hey, we can't get this med in any other way, and or things like low dose naltrexone. Um, there's folks that take that for various disorders. It's not available less than 25 milligrams. You'd go to a compounding pharmacy. Ketotifen, this is an antihistamine used for like some certain disorders like mast cell activation syndrome, things like that. Like it can often be hard to find. The only place that you could get it would be a compounding pharmacy. So if you're doing like really specialized treatments, you may legitimately access these compounding pharmacies. For most doctors out there, this is not something we're going to interact with. All right. So if you're going to do it, ensure the patients understand how to dose and deliver each time they use a different pharmacy. Right. So remember, this is just going to be vials and stuff. So like we need to understand concentrations. How many milliliters do we want? And if we have to switch pharmacies because we can't get it from this one anymore, make sure we know that like they're doing it differently. All right. Ensure they're getting from an FDA licensed 503A or 503B compounding pharmacy. So we want to make sure that the FDA has approved this, and they will have this designation of 503A or 503B. 503B pharmacies have stricter guidelines. So those would be, if you have a choice between the two, go with 503B. All right. So I hope you guys like learned a ton. Like I learned a ton about compounding in this whole story of GLP-1s. And I think this is something people aren't talking about. I think these GLP-1s have gotten so ubiquitous. I think when they first came out, there were all these like concerns and things, and then it just became ubiquitous. It became plentiful, and they're just being prescribed to anyone and everyone. I forget there's some figure like 20 something percent of people have taken these in the United States at some point, or it might have even been higher than that, at least once. Like people are taking, they're microdosing this stuff. They're thinking, oh, I want to get the heart benefits, I should take a small there's nothing to prove this yet. This may be something that's recommended in the future. Like these things, this is probably one of the most amazing medications that has come out in decades, that has the largest I mean, this obesity is the number one disease in America, and probably in the world at some point as a whole. And it causes like hundreds of other problems and cancers and everything. Like having a medication that potentially helps with this, and then like people want to lose weight. What is the vanity concern, right? So these drugs have just exploded. And I think a lot of folks they're not talking about these issues, right? Like, I mean, we went through all sorts of stuff. We talked about like the side effects, the black box warnings. We talked about the differences in folks with obesity versus diabetes and the hypoglycemia. We talked about nutritional issues. We talked about um, hair and skin. We talked about vitamins and minerals intake, eating disorders, drug interactions, shortages, cost compounding. There's a lot of stuff to think about when you're prescribing these meds. And I think a lot of docs that um, it's a lot of docs were afraid to prescribe these, and now I think that number is shrinking. But is their knowledge in how to prescribe them keeping up with the fact that they're like, well, I guess everyone else is doing it, so it must be okay. I'm not hearing that many problems, so I'm just going to start doing it. Do you know about all these issues? Well, I mean, I'm not hearing people talk about it. You come here to get this information. So hopefully folks find their way here. And I mean, these are the downsides, but like it doesn't mean you can't do it. But this is all stuff you need to keep into consideration. So that we had a 3-part like cautionary tale on GLP-1s here. And I hope you learned a lot and you feel more confident prescribing them because these are great medications. Listen to my benefits episodes if you want to hear about that. I mean, I'm a huge proponent of these, but I'm also like, we need to like be careful. And over the next episodes, I'm gonna go through them. We'll start with exenatide back in 2005, and we'll walk our way to the future. We'll talk about stuff that you've never even heard about. We're talking about survodutide. You know, we're going to talk about danuglipron and microdin, stuff on the horizon. So we're gonna start in 2005 when these first FDA approved version came out, and we're going to go in order. We're going to talk about each one of them. You're going to learn how to prescribe them, when to use them, why, what's on the horizon, what to be looking out for, and I think you're really going to enjoy it. This is going to be, this is the meat. You've got all the background information. You know what they are. You know how they work. You know why they're good. You know why we need to be cautioned. Now we're going to talk about each individual drug and how to use them. So I hope you will stay tuned for that next time, and I'll see you then.